Good morning. Hello, everyone. I'm Sylvia Choi, the president of the professional staff. On behalf of the Department of Pediatrics and the Grand Rounds Committee, I welcome you to our Grand Rounds event today. Whether you are joining us here in Rangos Auditorium or somewhere else virtually, we thank you for taking time to attend this very special presentation. First, a few housekeeping items. As a reminder for those who are virtual, there is not a separate link for the meet and greet today. The meet and greet will be integrated into the lecture at the end. If you would like to ask our speaker a question, please type it into the Q&A. If you would like to engage with the presenter, ask the webinar host to unmute or give you access to turn on your camera. If you're attending in person and would like to engage, just raise your hand and we will bring you a mic. Today is a very special Grand Rounds because we celebrate the memory of an outstanding physician, Dr. Howard Mermelstein. Dr. Mermelstein was a dedicated pediatrician, trusted friend, and compassionate caregiver who devoted his life to caring for Pittsburgh's children and their families. Dr. Mermelstein began his career at Children's as a pediatric resident in 1949. Over the course of his career, he became known as a respected mentor and published clinical investigator. Dr. Mermelstein also provided valued leadership to our medical community by serving as past president for both the Allegheny County Medical Society and the hospital's medical staff from 1989 to 1990. Here to tell us more about Dr. Mermelstein and speak on behalf of his family is his daughter, Jan Shaw.
Thank you, Dr. Choi. It's really hard to believe that it's been 31 years since our husband, father, brother, and beloved friend has been gone. I suspect that some of you have never heard of Howard Mermelstein before today. I would argue that we would not all be sitting here today if it weren't for the pioneering efforts of people like Howard Mermelstein, Gene Weiner, Paul Gaffney, and others. If one were to design a Mount Rushmore to represent Children's Hospital, surely one of the images would be the face of Dr. Howard Mermelstein. Dad was larger than life, standing at 6 feet 4.5. Those who knew him best never called him Howie. He hated that. He was beloved to this community almost from the time he was asked by Dr. McCluskey to be one of his residents in the early 1950s. He had an energy, grace, and class that were infectious. In practice, he always had a way of making patients feel like he had all the time in the world for them, yet did it with total efficiency. My brother-in-law, Paul Dubner, was lucky enough to practice with him, along with the late Bernie Michaels and Dick Paul in what was previously known as the University Community for 7 years before Dad's untimely death in 1991, after a courageous battle with lung cancer. He worked full-time, intermittently using oxygen, until 3 weeks before his death. He had a deep love for this institution, on whose staff he served as president, as well as on numerous committees. But his love extended well beyond Children's Hospital and the patients of his practice. He was deeply committed to the well-being of the practice of medicine in general, as evidenced by his service to the Allegheny County Medical Society, of which he served as president in 1979. He was deeply committed to the Pittsburgh Jewish community, in particular the Jewish Family and Children's Service, which is now called Jewish Family Community Service, of which he served as president and for which there is a similar award presentation every year. He was deeply committed to the city of Pittsburgh, living in Shadyside and Squirrel Hill, although born in Beaver County, and adoring his Steelers. But most of all was his unconditional love for his family. While this lectureship and annual award presentation began in 1994, the actual endowment was not fully funded until 2007. My mother, Beth Mermelstein, and we 3 kids, my sister Margie Dubner, my brother Bob Mermelstein, and I, as well as our aunt, Howard's late sister Eleanor Mermelstein, decided that his name should live on forever. So we created this endowment and award presentation. Special thanks to Carol Ashby, Amy Gelsheiser, and all the staff at the Children's Hospital Foundation for providing the nuts and bolts to get this done. I hope this provides a little background for the development of the criteria for the selection of honorees for this award, which this year is presented to Keith Summers, who would have been my children's pediatrician had it not been for my brother-in-law, Paul Dubner. The criteria for eligibility has been well outlined, so I do not need to reiterate them. The awardee is chosen by closed ballot, distributed by either regular or electronic mail to the entire medical staff, and reviewed by a small but representative subcommittee of the medical staff and I as a member of the Mermelstein family. Not only does Dr. Keith Summers work as hard as my father did, but he also involves himself in the medical community as well as the community at large, serving on many boards in order to make our world a better place to live. This is everything Dad stood for. The Mermelstein family is happy to honor Keith Summers with this award. Now I'd like to call on Dr. Choi to present the award to Dr. Summers.
Thank you so much, Jan, for sharing those memories about your father, and thanks to your family for allowing us to continue his legacy through this memorial lecture. I would like to thank all of you who submitted nominations for this prestigious award. As Jan said, this year's award is being given to one of our community physicians, and the nominating committee considered the many incredible and well-deserving physicians who are nominated. The one physician's career in particular that truly reflected the values that Dr. Mermelstein was so well known for is Dr. Keith Summers, who has been a part of the CCP Gill Pediatrics practice since 1988. Like Dr. Mermelstein, Dr. Summers' career reflects his lifelong commitment to teaching and the betterment of the profession. He's beloved by all of his patients. He has integrity that is recognized by his peers, and he's a leader not just in pediatrics, but is also very active in his community. He's dedicated to staying up to date and sought additional postgraduate medical training focused on plant-based nutrition and evidence-based lifestyle medicine. As a committed educator and community leader, he's done presentations to various community groups focused on green pediatrics and plant-based nutrition, as well as exercise and spending time in nature. Like Dr. Mermelstein, Dr. Summers has a strong commitment to community service and has been involved in many organizations, including Let's Move Pittsburgh, the Environmental Health Committee, and UPMC Committee of Clinicians for Climate Action, to name just a few. He has also had overwhelmingly positive feedback from families, and one parent in particular described their experience as, Dr. Summers is an excellent, compassionate, professional, knowledgeable doctor, and I am grateful to him for the time he takes with me at my children's appointments. Dr. Summers is a fantastic listener and willing to talk over issues. He is thorough and calming, but also funny and has a great way with children. After receiving a complex diagnosis at a difficult time for our family, Dr. Summers guided us through our medical journey. His invaluable advice and listening ear helped us rise above seemingly insurmountable obstacles on the way. We hope he continues to lead the stellar team at Gill for many long, healthy years to come. Dr. Summers is unable to join us today, but I'd like to share the following video message from him.
So grateful to be receiving the Howard Mermelstein Award for Excellence in Pediatrics. I was very fortunate to know Dr. Mermelstein early in my career as a resident and then in practice. I so admired Dr. Mermelstein and the standard he set, such an exemplary pediatrician, his commitment to the families, the children, and to the community and the activities of being engaged in. I want to thank the Mermelstein family for creating the Howard Mermelstein Award for Excellence in Pediatrics and recognizing pediatricians. And I hope I too can be a role model for future pediatricians.
Thank you and congratulations, Dr. Keith Summers. I will now turn the mic over to Dr. Catherine Guyon-Harris, who will introduce our esteemed Grand Rounds presenter, Dr. Daniel Shaw.
Thank you, Dr. Choi, and good morning. For those who don't know me, I'm Catherine Guyon-Harris. I'm a clinical psychologist and faculty in GAP. We are honored today to have Dr. Daniel Shaw speak with us on the Pittsburgh study. Born out of Children's Hospital Pittsburgh, the Pittsburgh study is a huge multi-cohort research study and advocacy effort focused on supporting child and adolescent thriving from birth through adolescence. Each age-based collaborative has their own outcomes and intervention targets of interest that support thriving for that age group. Dr. Shaw is here with us today to share about the Early Childhood Collaborative, which, despite the ongoing pandemic, has had impressive success in improving accessibility to parenting supports for caregivers of infants, toddlers, and preschoolers in our community. Dr. Daniel Shaw is the director of the Center for Parents and Children in the Pitt Parents and Children Laboratory. He also serves as distinguished professor in the Department of Psychology at the University of Pittsburgh, with joint appointments in the Schools of Medicine and Education and Clinical and Translational Science Institute and Center for Social and Urban Research. Since receiving his PhD in clinical child and developmental psychology from the University of Virginia in 1988, his primary interest has been studying the development and prevention of early problem behavior among children at risk for poor outcomes. He currently leads or co-directs 5 NIH-funded longitudinal studies investigating the early antecedents and prevention of child conduct problems and substance use, and directs a large-scale implementation study employing a tiered intervention model that will involve several thousand infants, toddlers, and preschoolers, entitled the Pittsburgh Study. Additionally, Dr. Shaw directs multiple implementation projects in various community agencies serving low-income families, including pediatrics, early Head Start, family centers, early intervention, and WIC. In addition to receiving continuous support from the NIH since 1991, he received 3 5-year consecutive Research Scientist Awards from the NIMH and NIDA, is associate editor of the journal Development and Psychopathology, has served on several editorial boards of journals, including Child Development and Developmental Psychology, and has been a member or chair of several expert panels convened by NIH, including recently serving as chair of NIH's Psychosocial Development, Risk, and Prevention Study section. Dr. Shaw has amassed more than 400 publications on risk factors associated with the development and prevention of conduct problems from early childhood through adolescence. Please join me in welcoming Dr. Daniel Shaw.
Well, good. Thank you so much. It is truly an honor to be here. I could spend the whole talk just thanking people to make all this work and everything. The title you can see a little bit different than what's on the, but I think you'll get the gist of it very soon. Let's see. Co-authors that I have to say something about. Chelsea Krug-Weaver, who did all the analysis here today, Ann Gill, my sidekick in this. Deb Bogan, a name that I'm sure is familiar to you, but was at the heart of the beginning of this, and some colleagues in New York, Alan Mendelsohn, and then our partners at the, this is the acronym slide to kill for, the Amy Mallon, who's the Allegheny County Department of Human Services, and Danae Wilson, also at the Department of Health with Dr. Bogan, and then all the staff of the Early Collaborative, including our community member group. And I could not leave this slide without thanking Liz Miller, I understand got another wonderful award today from the state of Pennsylvania, and Dr. Dermody, who have been incredibly supportive for all of this work the past 3 years and counting. So what am I going to do today? I'm going to tell you about, as Catherine foreshadowed, the Early Childhood Collaborative, ECC, of the Pittsburgh study. And there are a couple other studies I'm going to mention in passing that to tell you how we got from there to here today, and then get into the actual design of the Early Child Collaborative, as Catherine mentioned, an implementation to support parents of young children in the county. And then you'll be the first to hear this, some initial results of our work during the past couple of years. And then finally, some implications and hopefully future directions where we hope to take our work. So the story really begins with poverty in America. And just looking at this slide, you can see the likelihood of failing to be ready for school. I don't have to, again, I'm preaching to the choir here, but you can see these are huge, vast differences that have effects not just for these children, but these children's children and beyond, because this is passed from generation to generation. And so part of our work is addressing those barriers to try to make up for what, since we have a hard time affecting change and poverty. To address this, the last 23 or 4 years, I've been working with a model called the Family Checkup, which was created by my colleague, who unfortunately passed away, named Tom Deshawn. It's an intensive strength-based service for families. It was actually developed for adolescents, but Tom and I adapted it for early childhood. And as you'll hear about in a few minutes, an assessment-based model that tries to create dissonance between what parents want for their kids and how things are going now, which really motivates them to change. It's delivered by master's level clinicians, and it's really perfect at developmental transitions, birth, the terrible twos, I like to have it on. It was recognized back in the early Obama administration days as one of 7 evidence-based models that could be used and supported by states, but it remains much of a secret because we didn't really have a huge infrastructure to support its implementation. A recent cost effectiveness analysis suggested it cost about $480 a year per child, which is relatively modest compared to some more Cadillac programs that are $5,000 or $6,000 a year per child. So we think it fulfills many needs simultaneously. Rather than say anything more, I'm going to show you a video, and you'll notice the person wearing this outfit is the same as here. Let's see. Please, I have to go over here. I'm not following.
We know that parents want the best for their children. We also know there's a lot of challenges.
And say that parenting is the most rewarding yet the hardest job they've ever done.
Family checkup is an effective method for addressing the many challenges of parenting.
Like a pediatric visit, we meet with families for a checkup, but this time it's about their child's development and behavior.
A trained family coach will first spend time getting to know the family, then share direct feedback about child and family well-being.
Building on strengths, we work with families to reach goals they have for their child.
These 2-day meetings take place at a family's home or wherever is most convenient.
Parents also have the option to continue meeting with their family coach after the feedback session to support their child's development.
The family checkup is an evidence-based 2-generation parenting intervention designed to prevent child problem behavior. The family checkup is brief, typically taking place over the course of 3 sessions, each about an hour long.
The first step is the initial interview, and it's designed to build rapport and a relationship that will support the remaining components of the intervention.
We really, right from the start, are partners with parents in this. They know their children best, and they are their child's best teacher. They make time for us and our schedules. This person's coming to help me become a better person and a better mother, and also help my child excel as well.
Second step is a comprehensive assessment that explores child and family adjustment and relationships. The assessment includes questionnaires about areas that impact children and families.
A unique component is the careful use of video-based assessment, where parents and children take part in activities that demonstrate their patterns of relating and communicating.
It was a great experience. They filmed it so I could see just different stuff as far as like playing with her and how she reacted. And it really lets them see themselves in a different light. It works.
The third and most powerful step of the family checkup is the feedback session. The family coach meets with parents to share the results of their assessment in a conversational format.
The purpose of this feedback session is to enhance caregiver understanding about their strengths and challenges in a way that motivates them to take action.
Parents are then invited to set goals for their child and themselves to support and maintain strengths.
as well as address areas of concern.
They talked about social skills. They also talked about coping methods.
Very still encouraging and empowering, like keep up what you're doing. After the feedback session, parents can select from the menu of options for follow-up services, including managing child behavior and improving parental well-being. How often would you like to meet?
At this point, I think, once a month.
Depending on what the parent may want, I may start to work with them weekly or seeing them monthly, or maybe do some phone check-ins, or even just provide them with some general resources.
More than 25 years of research shows that the family checkup leads to positive outcomes spanning from early childhood to adolescence.
In early childhood, these positive outcomes include better self-regulation skills, fewer conduct and emotional problems, and less conflict with parents. At school age and through adolescence, these positive effects translate into better academic achievement and better relationships with peers and teachers.
The family checkup works by efficiently supporting caregivers, enhancing parenting skills, and addressing contextual factors that present barriers to optimal parenting. For example, the family checkup has been found to lead to reductions in parental depression and improvements in parent relationships so they can best support their child's development.
I've been able to express myself to get a real good reflection of my interactions with my daughter, continuing down the path of accomplishing my goals.
I more so wanted to be here mentally and physically for my children. I also wanted my children to be mentally and physically healthy. It's very encouraging and empowering.
The family checkup.
Building on strengths to give children the best chance for success.
Yeah, and as you saw in that, there was a goal sheet planted. This is what parents generate with us over time. So it feels very, very collaborative. They can change where those stars go, but those stars are based on established assessments. So we can tell where parents are compared to other parents. Are you clinically depressed or not? Or is your child showing above average or normative behavior? Are they getting to milestones on time, like toilet training and walking and things like that, and when they're quite young? And at the end of that session, parents then say, we say to parents, if you're going to change anything in the next year for your family, for your child, what would those goals be? And we walk through those and how you want to accomplish them. The important part is they can do this on their own, or they can entrust us. And about 60 to 70% of families want follow-up sessions where we can work on it. But again, it's generated from them. They keep these goal sheets on refrigerators and things to show their support. And as was mentioned in the video, we have a lot of positive findings. This sample, which was part in Pittsburgh, part in Eugene, Oregon, where Dr. Deshawn was at the time, and part outside in rural Virginia, outside of Charlottesville, we have 45 peer-reviewed treatment effects for the family checkup. Those in preschool include language, BMI, conduct problems, parenting, you name it. We have it in early childhood over time. And those improvements in child behavior tend to be mediated by improving parenting, by improving maternal depression, getting, within the home and trying to improve the environment for the child. No effects for culture, even though we're working with Latino, African-American, and white families across site and rural, community, suburban efforts. When kids get to school age, the treatment effects continue, less oppositional behavior, less conflict with teachers, even less risk for suicide from ages 10 to 13. This treatment continued. Parents could opt in all the way to age 10. About 60 to 70% stayed with it during the school age years, even in better performance on Woodcock-Johnson academic and better use of service delivery. So we're empowering parents to ask more, to get services for their families, faster rate of inhibitory control, better peer acceptance, lower levels of conduct problems, all the way through age 14, et cetera, et cetera. And I could go on and on about it, but it's not a panacea. So in our sample, which was totally a WIC population recruited across the country in these 3 sites, we found that the intervention worked much better for families at higher risk within a low-income population. So for those who know about effect sizes, these are the Ds on the far right of here. We got a very modest, and I mean extremely modest effect sizes for WIC families who are low income or very high income within a low income population, or low income single or two parent families, but other low risk factors. You can see on this slide 0.08, 0.01. That's like flipping a coin. That's nothing. But for families who were low income, had a depressed parent, had a history of involvement with child protective services, or a history of antisociality in the parent, that's where the action was. Now, at the same time this research was going on, we were sort of approached for what I call an arranged research marriage with another intervention. This was an outside group that brought us together. And my now long-term colleague, Alan Mendelsohn up there on the right, and Pamela Morris, Alan Mendelsohn on the left and Pamela Morris on the right, told us about another program, a program that was universal and seemed to work well for all low-income families, not to the extent when they had really high levels of stress. And we thought, what if we combined forces and created what you're going to hear about the rest of the talk, a tiered program where families would select ones that met their risks and challenges over time, as well as their strengths. So the video interaction project complemented us, and we thought would be a better fit for families who, yes, face economic resources, but otherwise were, I would say, inadequate to even good shape in terms of what were they providing for their child, but could still benefit from some basic parenting skills when their child was born. The beauty of it, Dr. Mendelsohn happens to be a pediatrician, and he is very aware of programs like Reach Out and Read and Well Child Visits, which happen, as you know, often in the first 2 to 3 years of life. So again, preaching to the choir here, but we know that pediatric primary care is a wonderful platform to use in early childhood. Some estimates say as many 91% of children age 2 had at least one well child visit. This is back in 2011. I think it's still in the 80s for more recent data. Early and frequent contact, low cost, and the success of Reach Out and Read, we wanted to leverage that. And in developing what's called VIP, Video Interaction Project, Dr. Mendelsohn used that research and that base to, it's a sort of Reach Out and Read on steroids in a very positive way over time. So as I mentioned, he developed this at Bellevue Hospital, New York City, primarily Latino families, some Black families as well, very few white families. Implemented by an interventionist who builds an ongoing relationship with family at the time of the well child visit. So at Bellevue Hospital, where Dr. Mendelsohn developed this, waiting time is 2 to 3 hours for well child visits. You know, just sit with that. That's a lot of time for families to not only entertain the other children, but just sitting there. And so he capitalized on that. And these visits are 25 to 30 minutes over time. Again, designed to build on Reach Out and Read, individual sessions. Every time the parent and child take home a toy that they're going to use during this session, and you can see the core activity, you're going to see this in a second, is video recording and giving immediate feedback to parents, much like we do in family checkup. And in fact, let me show you a very brief video of what it's like.
You know, imitate those sounds and then expand on it.
Love it when I talk to her.
I love it. She's clearly communicating with you. She loves your voice. This is a book. It gives you a lot to talk about. It gives you lots of colors. You can talk about the sound. There's different textures, so you see how things change.
What's that over there? A fishy. What color is the fishy? It's pink, right? Your favorite color besides purple?
You're constantly talking to her throughout the whole sharing of the book. It's so, I love this part. You related it back to something that's very much to her. What would you like to continue doing with her actually with the book? What would you do? The same thing, play with her, like show her the different colors. Oh, and also like I also make up stories, Absolutely. See you soon.
Hope that gives you a feel of what goes on in these sessions. So the integrated model, which it's a little confusing, is called Smart Beginnings, VIP with family checkup, has this universal component on the left. You can see during health care, pediatric child visit that can be delivered by someone with a BA, bachelor's in child development. So much less, it's about $250 per child per year. Very cost effective for families that have additional issues that get in the way of parenting. We then would offer the family checkup. This was the idea, a more experienced clinician to deal with those layers of stress and trauma over time. And we know that VIP has been tested and it doesn't seem to have different treatment response across the spectrum, but sometimes less effects for those at very high risk because of the level of training of the VIP interventionist. At a larger level, stepping back, you can see this tiered model. We're going to offer it in primary care. And where did we choose to do this? Bellevue Hospital and Children's Hospital, Oakland, over time. So if you didn't know it, VIP has been offered, as a big secret, at Children's for the last 8 years, since 2014, when this Smart Beginnings project began. And this was kind of the beginning of our tiered model. And you can see everyone coming in would then get VIP. And for those with additional risk factors, we would also offer family checkup. So not a very complicated tiered model. Okay, flash forward to 2019 and the beginning of the Pittsburgh study. Finally, he's talking about the Pittsburgh study. And I, again, could spend hours talking about the different layers and levels. As Catherine, thank you very much, Catherine, alluded to, there are really 6 different age cohorts, plus cross-cutting committees of policy in place, data accessibility, and health services research. We're just going to zoom in today on the infancy and toddler preschool, which has, since this slide was made, now called the Early Childhood Collaborative. And again, this is Liz Miller's creation to a large degree. And the Early Childhood Collaborative really started as a result of work that Deb Bogan initiated and allowed me to be part of it. So this is our collaborative here, and you can see early childhood, very important that a lot of community members, we talk to parents, former parents in the community, we have a scientific review group, but these are kind of the major players on a more day-to-day, if not week-to-week basis. Myself, Amy Mallon at Department of Human Services, Danae Wilson at the Allegheny Health Department, Deb Bogan, in a less central role than she was at the outset there, Chelsea Weaver-Krug, and our outreach coordinator, Val Chavis. Ann Gill should be up here. Hell, Dr. Hoberman should be up here because of all the cooperation that we've gotten in working at Children's. And this is just literally a snapshot of our supervisory team. It would take pretty much a whole screen to fill that, but these are the folks that are calling the shots on a day-to-day. And Catherine, who introduced us, is part of that. Okay, what's our goal here? Accessibility of services. We have a limited capacity of programs to engage families. I didn't say we have a limited number of programs. In Allegheny County, relative to the rest of Pennsylvania, we are resource rich. Families are not using it. Why? That's the question. We want to be able to capture the heterogeneity of risk here. We know within low-income families, certainly between low and middle and upper middle, low-income, economically less and more challenged families, there's huge differences in what parents want, of what they, in raising their child and information they need. There are really no existing populational intervention implementations to address these gaps of heterogeneity of risk and challenges, as well as strengths, and programs designed to address those. So this was our vision a few years ago, to address the chasm between our knowledge of early promotive factors and evidence-based interventions. We have the knowledge, we have research. Some of you might have seen me talk 5 years ago. That was about identifying what those were. We have that. That's not the issue. But the chasm is having all that information, that technology, and our ways of engaging families. That seems to be one of the big missing pieces here. We're using principles of behavioral economics and something called common sense to make these programs more accessible at locations families already use. We're not trying to reinvent the wheel. We're trying to do the opposite of that, but widen locations where families might make it easy for them in the spirit of behavioral economics to do the right thing, just like opting in versus opting out of retirement plan. If the default is opting in, you're more likely to do it big time. We want to make it easy for families to take advantage of these supports. We're using this tier-based approach, which you heard a little bit about, but we're going to expand it. We like VIP, we love family checkup, but there are other interventions that might be more catered to families' needs. So we're going to include a few more over time. We want to help families, number one. We want to support it, but we also want to develop a system that we hope might be adopted by social policy folks at Department of Human Services, the Department of Health. Hence, they are our dear partners in this endeavor. How do we choose these interventions? Well, you heard about VIP and the Pittsburgh study. They had to have evidence of long-term intervention effects and promoting children's readiness for school. They had to have a success in engaging families. And in our Smart Beginnings trial here, when we tested VIP at Children's Pediatrics, I think 76% of families had at least 5 of the 6 sessions in the first year. And I think only 3% had no sessions. So that was a testament to, hey, could we translate an intervention that had been used previously in New York with predominantly Latino families to predominantly Black and white families, and that worked quite well. Could we offer it in traditional settings or non-traditional settings outside of behavioral health, such as pediatric offices, family homes? VIP had never been used in homes before. At WIC, where we've developed ability to have space there if WIC would ever reopen and deliver services. Family support centers, now called family centers, and of course, online. This was all developed before something happened in March 2020, right? We added another piece, of course, which was with COVID, the ability to engage families remotely, which we weren't prepared for at the time. And you can see the list of programs. Healthy Families America is much more intensive. It's every week, beginning during the prenatal period, all the way till age 3, if parents want it, every week. Family centers are 27 of them that are out the center. They can provide everyday resources. Nurture program does online, you text online more for our more I would say economically less challenged families who are very facile in typing. And then Text for Baby, anybody here could enroll in it right now. It's just a passive program where you get information about raising your child. So you can see this continuum of intensity over time. How did we set this up? Well, we thought it would be great if we could screen families to better enable them to pick programs that met their needs. So recruitment was at McGee Women's Hospital, you all know, also at pediatric centers, at WIC. This was the original plan. They all would take 30-minute survey and then reimburse $30 for their 30 minutes of time. Again, making it easy for them. Some are already waiting in the waiting room. Importantly, those were scored in real time. So when they finished the survey, we could have an answer for them and give them choices, show them links to videos. The one VIP video you just saw, that's what our parents see, a shorter version of the family checkup if they're interested, if they fall in that category over time. And then they're given these choices in our high resource, lower challenge group. You can see those 3 choices, lower resources, but lower challenges, VIP and nurture program. And then when we're getting into the higher risk families, they get offered VIP or family checkup or Smart Beginnings, which is both of those programs, or Healthy Families America over time. And so we ended up with these 4 different groups. And you can see Chelsea Weaver goes crazy trying to keep all this stuff straight. You can see range and intensity delivered at convenient locations. Our goal was to make sure that the reason families said no, had nothing to do with location and convenience. We wanted to make it as easy. We'll come to your home. We connected with Allegheny County and the city library system. We'll go where you want us to be. Obviously, if someone was coming in for a well child visit, we want to capitalize on VIP and offer it there. Catherine actually delivers family checkup at Children's Pediatrics. I mean, we want to make it as simple as possible over time. Importantly, families get this screen every 6 months. They get paid for it. So if family circumstances change and a higher level of stress is there, they can opt for a different intervention or a supplement one they're already using, or pick a new one if it's not working out. And this goes on till they're age 3. And then after that, an annual assessment at age 4. And then we turn it over to another group in our larger Pittsburgh study. We had great plans before COVID. We were going to create these wonderful hubs where there were multiple resources. If you're familiar with Hosanna House, you know, there's a WIC there, there's a FQHC there. There's wonderful places to go. Children's Hospital clinics in Oakland and Turtle Creek, family centers throughout, Carnegie Library, all that came crashing down with the pandemic. This was our great plan here. I should note, WIC is opening in McGee Women's Hospital, hopefully in January, which will be a great service for hooking up our prenatal with our recruitment team over there. But this was our master plan. Then came COVID. We had to change a lot. It took us a couple of months. We had to learn how to offer both VIP and family checkup remotely, set all those videos up. We were recruiting newborns at McGee. The first question is, imagine this, you just had a baby. The next day you get a call. Are you interested in research? Well, about 60% people said no, understandably. When we did it in person, about 60 to 70% say yes. So we've lost some momentum there over time. Fortunately, that's changed, and we've been live again at McGee the last several months, and recruitment is going up again. We also began recruiting with flyers at Turtle Creek Children's, as well as here. We extended it after starting with just infants. We're now up to 0 to 4. WIC recruitment, that's been our goal, to get older children from there, and they've gone back and forth, mostly back, and now they're recruiting via telephone only. So we've been stymied along the way, but we hang in there over time. We're also connected with Primary Care Health Services, which serves 8 FQHCs over time. So we're getting there. Finally, some results. What have we found so far? Well, the good news is we passed the 1,000 barrier finally after a couple of years. Where this says 1,024, we were at 1,000. This was done last week, and now we're at 1,055, and that's probably inaccurate too, because that was Monday earlier this week. When you look at this slide, you'll see a couple things in orange. We have P1s and then P2, parent ones and parent twos. Parent ones, you can see about 96% are mothers, a few fathers, and among the fathers we've been getting, and we are trying to get fathers, about 88% of that P2 group are fathers. The sample is about evenly split. This is like election results coming in, a white and black. You can see our black families recently started to be slightly larger than our white families. And this reflects getting more families from WIC. As we're texting those parents, we got permission at the state level to text WIC families. And now it's a matter of, do we have enough recruiters in? And then do we have enough interventionists? So we're constantly playing whack-a-mole to keep up one and the other. You can see the sample is, about 40% married, another 13% living with a partner versus single parent, reflecting more and more lower income, but not predominantly lower income families. This is from recruiting from McGee and less recruiting than we would prefer from WIC and other sources. We're about to start recruiting, or we have been sort of by indirect methods, at Children's Oakland and Children's Turtle Creek, where we hope to also provide services. This is just the background characteristics. You can see about 58% of the families so far are making less than $30,000 a year. We want that rate to be about 60, 65%. So we're getting close to that. About 37% are on WIC, and about 53% are eligible for Medicaid over time. All right, to some results. We have these 4 groups that I outlined earlier, and they're falling pretty evenly into these groups. You can see about 25% are higher resources, lower challenges. These are folks being born at McGee, and then our group 2 over time. Group 2, you can see about 82% have low income. When we get to group 3, you start to see families who are having some, I would say, serious risk factors. 37% of them have a history of hospitalization before for mental health issues. 70% qualify for clinical depression over time. So these folks are getting more family checkup and or VIP over time. And then we have our group that's we call serious challenges, where there's almost 2/3 of them have had a history with child welfare services, 26% incarceration, 10% opioid use, and 41% recent homelessness. That's in the last 2 years. That's not 10 years or anything like that. So these are very serious issues. When we get to discussing a program called Hello Baby, this is some of the same folks who are in those groups. So this is the big news so far. If you are clinically depressed, that is, you're scoring above 16 on our Center for Epidemiological Studies depression scale, 80% of those families are engaging in one of our more intensive interventions, VIP or family checkup, or both, which I think is really good news for society that 4 to 5 of those families are doing it. Overall, almost 83% of families have selected a program, at least one, if not more, when they're given the choice, when it's convenient, when it's accessible. Again, so it's a take-home message. You'll recall, though, that we're also redoing these screens every 6 months. And when we follow up those families 6 months, we get 20 more families. And at 12 months, 7 more. So cumulatively, our rate of engagement is almost 86%, which is, we're really happy about that. We didn't know what to expect, but we know in practice from our failures in the past, we get about 15 to 20% of families engaging in these interventions. So we're really happy about that. Percent of parents who selected a program. The other piece I think of good news is you can see if you are well-resourced, your challenges are low. This is the green block. You still have about a 2/3 chance of selecting an intervention. But frankly, we care a lot less about those families. They're doing pretty well. As you'll see, when they do select a program, it's going to be low intensity. The good news is there's a significant difference between being in group 3 and 4 versus that first group in your probability of selecting a program, where rates are above 80% if you have, I would say, moderate to severe issues that we know from our past research and others are related to children's school readiness and several other issues like suicide risk, violent behavior when you get to adolescence. And so one question is, what programs are they selecting within these different silos? And you can see within, does it show up over here? No. In the first column over here, you can see that if you're in this low challenge, high resource groups, you're likely to select Text for Baby, with some families selecting Nurture Program. In that second group, you're very likely to select Video Interaction Project, and some families also selecting Nurture Program. If you're in the moderate group, again, it's pretty even, but VIP and Family Checkup, those are your choices. Interestingly, about 1/3 families, when asked, would you like VIP or Family Checkup? They then see the videos. They say, give me both. We didn't expect that. I'm not sure we can afford that, but that's what's happening. And then Smart Beginnings is the combination of that. And that's what families are selecting. We're still waiting for the Healthy Families America video, which we think would prop that up quite a bit. Very good. Our initial findings, we think, support the Pittsburgh study's strategies to engage and support families. We're offering families choices in both program and location of service delivery. We believe this approach is respectful, it's targeted, it's being delivered at many locations parents want. And they're kind of, I don't know if they tell us this per se, but I would say their actions are speaking pretty loud at this point in terms of saying, yes, I can make it. Clearly being able to do these things in their home remotely and shortly more in person has made a big difference. We're still hoping to go back to family centers and to WIC and to libraries if families want that. We have a central system for engaging families and screening and services. And again, we've been especially successful for families at greatest risk, often in society, the most difficult to engage because of mistrust, because of generations of not having faith in what they're getting. We've had many challenges, the pandemic being one, and that has caused staff turnover throughout. And then sustaining funding. This is not cheap work. We have like 14 interventionists on our staff. That's expensive. And so sustaining it, and the reason we've been partnering so much with the health department and the county, the Department of Human Services, has been to look for sustained work over time. When we think about what's next, what's coming up in the near and distant future, well, certainly we want to continue to recruit families, engage families, providing these evidence-based programs. We want to see if this is working, right? This is not a randomized controlled trial, but families who say no to us consistently can serve as a control group, and we can match them on characteristics to families that say yes, who look just like those that say no, and follow their children's outcomes. We actually have permission from about 95% of families to get their medical records, to get their educational records of their kids when they get to school, and records from Department of Human Services. So if maltreatment does occur, we will know about it in the future over time. A big initiative has been to combine forces with Hello Baby. We feel like we're part of Hello Baby. Our family checkup intervention has now one of the 2 interventions being used by Hello Baby. So we want to get closer over time. Right now in Pittsburgh, families also being referred to the family checkup from Children Protective Services, Early Learning Resource Centers, all family centers, and family court, which was a product of one of our interventionists work, Dr. Frida Reed. We've also been able to combine forces with the Department of Human Services to obtain funding from the Heinz endowments to support some of our clinical staff, which we hope is the beginning of kind of turning this over to the county over time. We also, having this data, working with different collaboratives within Pittsburgh study has enabled us to get 2 NIH grants. One is a secondary data analysis with 4 other cohorts involving Dr. Mendelsohn at New York and in Flint, Michigan, where you all know about the quality of the water and life for families there. And we've been able to look at different interventions that were offered pre, during, I hate to say post-pandemic, I would say late during the pandemic, and see whether those interventions, the timing of those interventions, actually affected change in kids' school readiness over time. Another one has been done with Dr. Janet Katoff, the McGee Institute, trying to combine forces with what we know about cardiovascular risk and integrating that into home visiting programs so that parents were thinking about losing weight, reducing their blood pressure, have preeclampsia or gestational diabetes can be met. And while we're learning about parenting, also learn about ways of improving their own and their infants' health over time. And then recent conversations have led us to thinking, could we adapt some version of our tiered program at Children's Hospital in Oakland, in Turtle Creek, and other centers where there's a high percentage of families who are economically challenged over time. So in closing, we offer the screening at 6 to 12-month intervals from children 0 to 4. Families are offered this choice of programs on an assessment to assess both strengths and challenges. They have a choice is kind of the take-home message here. They can select more than one or change programs over time. And all that is catered within a central system for screening and providing services, and with strong linkages across families' systems and to get data. And of course, the delivery at many locations, including their homes, to make it as convenient as possible. We believe it's respectful and it's aligned with family choice. And in closing, let me just thank, you can see all the funders that are and our partners here at the top, including the Heinz Endowment down below, but UPMC Children's Foundation, we wouldn't be anywhere without them to get this project off the ground. So thank you so much for your time. If you want any questions, of course I will take now, but if you want to get in touch with me, here's some addresses and everything. Thanks very much.